true honor to introduce my next speaker, or our next speaker, Dipti Itchhaporia. Sorry if I've not quite got that right. Most of you may well know Dipti, previous president of ACC, and I think, part of this society is making sure that we don't just talk to ourselves and we don't just listen to ourselves, and it is a real honor to have someone who has had such leadership experience, who I suspect will recognize a lot of what we've talked about in terms of the challenging, but it will be fascinating, Dipti, to hear your perspective. Thank you very much.
Thank you very much. I'm just trying to bring up my first slide, so. Is it, okay, perfect. So some of the stuff that I'm going to be talking about, I was asked to talk about artificial intelligence or augmented intelligence in the future of cardiovascular medicine. So sort of more of a broader step back just from the world of CT and see what we can do. I have no disclosures for this talk. I'm going to talk about the importance of AI, which most of you already appreciate, the use of AI in cardiology, not just in CT, but what about other areas of cardiology, and then what are the challenges and opportunities? If you think back, when was AI, the term AI was actually coined in 1956, so a long time ago. The concept is quite old, and in 1997, IBM actually had Deep Blue beat the Russian chess grandmaster, and then in 2011, we had IBM Watson that won the quiz show Jeopardy! And then, of course, we all know about ChatGPT, which was released in November of 2022, and I'll circle back to that towards the end of the talk. And now it's sort of gained a popularity, especially since ChatGPT. If you look everywhere, everybody's talking about artificial intelligence. In fact, if you look at the New England Journal over the last year, there's been a lot about artificial intelligence, and in fact, in the fall, they're going to actually have a journal dedicated to this, and they've had a series of articles talking about it. And everywhere you look, and you already saw some of the examples of the New York Times and the popular media talking about AI. But AI has really had a place in healthcare, and we all believe that. And in fact, the FDA has cleared AI algorithms. Here's the breakdown for the number of FDA-cleared algorithms across the medical subspecialties. So in radiology, as you would expect, 431. In cardiology, it's 66 up to March of 2023. And if you look at all the other fields, hematology at 14, neurology at 10, everybody else, nobody comes close. So cardiology is really leading the way in terms of medical subspecialties. Now, I will tell you that in spite of the fact that there are all these AI algorithms, one of the things that a previous speaker alluded to is the fact that not all of these are billable. And so this is one of the issues that will be there. Now remember, these are just the clinical patient-facing AI algorithms. There are hundreds of other non-clinical algorithms that are already embedded in the back end of IT systems to sort of help speed our workflow, improve efficiency, complete time-consuming tasks. And I will say that I think in the future, some of this will have to be embedded into our workflow better, and it will also have to be in the packaging rather than us buying piecemeal all of this, because there's no way to pay for all of this piecemeal. Now, the AI healthcare market, how does that look? Well, in 2020, the global AI health market was valued at $4.9 billion in the United States. In 2021, the startups, in spite of, the startups got $2.5 billion. And I will tell you, during COVID, even more money poured into it. In 2024, the market is supposed to increase to $45 billion. And the predicted compound annual growth rate of AI in healthcare is 45%. And we can feel it, right? We can all feel it with all the companies. We can't keep up with the names, the places. They're all over the world, everywhere. And the reason there's this drive is that it's believed that it can save dollars in terms of healthcare. And we're always being asked to bend the cost curve, particularly in cardiology. Why? Because it's the #1 killer, and obviously we spend so much money on cardiovascular care. So now, why has AI come into it? Well, it's a digital world, and the digital world has already allowed us to be an enabler for AI. Data is really the new game changer, right? With all of these digital devices, every day a patient wants to send you information from what they've collected through their smartphone, smart ring, whatever it is, their smart socks now, all kinds of information. And the last thing you want is they say, oh, can I send you that? And you smile and you say, not really. And so, because what can you do with all this data? And I think that organizing all of those different digital data that we need really to improve patient care the way that we anticipate is time-consuming and slow. So to reduce that human effort involved and to decrease the time, AI and, of course, machine learning is being employed. So data, data, data everywhere that you look. And really what else is happening? Medicine is really becoming an information science. What an individual patient wants is for you to look at all of their information head to toe, and tell them what's wrong with them now, what potentially can go wrong with them, and how to keep them healthy. And so I think big data, new knowledge in medicine, the thinking, training, and tools needed for a learning health system, which is what we've become, is we've evolved into a learning health system. And I think this is where AI machine learning is helping us get there. And as you know, we started off with AI, and then we've moved to machine learning, and then deep learning, and all of that. It's particularly the deep learning. It learns from our past mistakes, but it requires a large amount of data, which is what we're sort of grappling with. So artificial intelligence in cardiology is here to stay. This is a paper that I wrote a few years ago, and really highlighting what are the uses of AI in cardiology. Well, obviously, streamlining and decreasing human work. We want automation. We need automation. We want to be able to generate crucial new knowledge for risk prediction, perform novel diagnoses that were not possible before. And then I think it can also assist us in making not only the prompt diagnosis, but improving our interpretation skills and maybe delivering that accurate, and as Andrew said, more personalized care. And then there's, but of course there are some major ethical issues that can arise from the implication of AI predictive modelings. And so although researchers can continue to improve the accuracy of clinical predictions, I think a perfectly calibrated prediction model may not significantly enhance clinical care. So even if we get all this information, how is this really going to translate into improving our clinical care? And I don't know that we know all the answers to that. And then an accurate prediction of a patient outcome does not tell us what to do if we want to change that outcome, right? It just says the outcome is going to be different. But how do we change that outcome? We don't really know the answer to that. So sometimes prediction is good, but I think the patients want more than that. They want to know, if you can predict it, how are you going to change it? And we don't know that AI has gotten there yet. So there's lots of issues. But AI-driven care is certainly here in cardiology. You see it in interventional cardiology. You heard about how it's helping in structural heart disease and electrophysiology, in cardiovascular imaging. And it really has played the biggest role in imaging. And I think also there's a lot of great applications utilizing just a plain ECG and the amount of information that we can glean from that. So the big thing, I think, is that there's discovery of new insights with AI. Today, data that we get in imaging comes in a digital form, but it's converted to analog images, right? And what we want is there's information lost when things are converted for our eye. And then remember, once we see an image, we convert it ourselves in our visual processing. So AI models can perceive raw data as they are, and that has the potential to minimize bias, data loss, and noise. But by combining different input data and different processing methods, maybe it's possible to really discover new relationships in data that we as humans have not been able to discover. And I think that's the promise that we're looking for. That's what we want. And so, I mentioned imaging is the place. So AI, there's certainly a place in echocardiography, not only in functional left ventricular assessment, but to make some cardiac disease diagnosis. How about automated segmentation of cardiac cavity? And then standard section recognition. There's a lot of work in that. AI in nuclear cardiology can be used in a variety of tasks as segmentation, disease diagnosis, and outcome prediction. And certainly in CT, in this crowd, I don't have to say, but I think it's very interesting. There's scar imaging. There's not only the FFR and the CT perfusion, coronary plaque characterization, calcium quantification, but also epicardial fat, looking at that, valvular and arterial disease, atrial disease. I think there are some other things that sort of help us. And this radiomix basics, I think radiomix is very interesting. It's the extraction of a high number of quantitative features in the region of interest, right? So this allows for novel imaging biomarkers, tissue structure, and underlying histopathologic phenotypes. I think this is where you look at the image intensity, the shape, the texture, and that hopefully can help us overcome the usual subjective nature of the image interpretation. And then this extracted data is processed with machine learning, and this enhances the existing clinical data for improved diagnosis, prognosis, or assessment. So this is what it looks like, the workflow for cardiac CT, and what you're looking at is not only the shape, intensity, but the texture, but looking at it in all these different forms to get the analysis for feature reduction, modeling, and then diagnosis and prognosis. As we know, cardiac CT, we know that this augmented intelligence can help facilitate reads more efficiently, reduce cost, increase accuracy. I don't need to tell this crowd. I mentioned to you that ECG is an area which is really hot. At Mayo Clinic, they're doing a lot of work looking at this AI and ECG, this AI ECG interpretation. And that can not only improve diagnostic accuracy, but it can help with risk stratification. We already know that there are wearable devices, implantable loop recorders, watches that are giving us a lot of information, and they're embedding AI to sort of make the patients aware of arrhythmias, and that's what the patients want to send to us. But this is certainly something that we're seeing. This feasibility of deep learning, the CNNs and the EKGs have been demonstrated, and there's a lot of information that we can get, not just what the electrical activity of the heart is, which is what we look at, but hopefully it can detect left ventricular dysfunction. There are some studies looking at predicting who's potentially going to have acute coronary syndrome from their ECG, atrial fibrillation, hypertrophic cardiomyopathy, even predicting an individual's age, sex, and race based on the ECG alone. Now, the question is, what's the evidence that this is going to impact patient outcomes, and what are the challenges in really putting this in a real-world implementation? But I will tell you that there's data looking at if somebody comes in with shortness of breath in the emergency department, looking at their ECG, and there's been some models that show that that predicted the LV dysfunction better than just getting an NT-proBNP. And that's been validated in several different places. This is the work from Mayo Clinic that looked at the AI ECG, and they took all of the clinical data on these patients and married them with the ECG data, and not only did they predict the age of the patient, but the probability of a low ejection fraction, probability of hypertrophic cardiomyopathy, and the probability of atrial fibrillation. So very interesting work there. This is from their paper that talks about the potential future applications of AI ECG, not only for atrial fibrillation, but also identifying patients who had sudden cardiac death who should receive an implantable cardioverter defibrillator, and then going beyond left ventricular ejection fraction in patients with ischemic or non-ischemic cardiomyopathy, certainly risk stratification in these patients, and then patients that may be at risk for having an exacerbation of their heart failure. So lots of really interesting things. This was a study that was published in JACC that looked at training, validation, and testing of AI-based EKG screen for hypertrophic cardiomyopathy, and really great sensitivity, specificity, but again, not something that you normally think about doing, but certainly something we can use. This is a deep learning model to detect significant AI using electrocardiography. Now, who would think, looking at the EKG, that we can talk about something like AI? This was a huge study with almost 30,000 ECGs, and then they did a deep training to look at if you could predict how much aortic regurgitation these patients had. AI also is used in cardiac imaging for risk stratification. I don't need to tell you all of this. I think this, as an interventional cardiologist, I find this very interesting in STEMI management, particularly in women, to remove biases. This was a paper by Martha Gulati that showed AI may be able to use predictive modeling of the features of STEMI to provide a standardized approach for care, which can eliminate implicit bias in the care of women and improve STEMI care and eliminate sex disparities. Now, you think this sounds far-fetched, but I just had a patient recently come to see me, and she said that she and her husband went to a physical for an internist, and her husband had an ECG, but the doctor didn't think she needed to have an ECG. So I think with these things, these biases do exist, and we do need to think about ways to maybe sort of overcome those. Certainly in the heart failure area, AI has been playing a role to help standardize treatment strategies, and the machine learning-based models are better at predicting readmission and mortality in patients with heart failure rather than conventional statistical models. And then sometimes who's best for cardiac resynchronization therapy, sometimes that's not so clear, and I think we can use machine learning to sort of help us guide that therapy more effectively. Certainly in the area of congenital heart disease, there's a lot of opportunities for artificial intelligence, deep learning to not only make prenatal diagnosis, procedural planning, postnatal, and then cardiac imaging and precision medicine in this group of patients. I think that auscultation is an important examination that we all do as clinicians, and actually analyzing sound is one of the areas that AI excels in, and this was a study looking at the detection of left-sided valvular heart disease, both aortic stenosis and mitral regurgitation, using AI. So I think there's a lot of things that we can think about. This was a study that was done that in the prevention world that said that when we use pooled cohort equations to apply prevention, that sometimes we can miss certain populations, particularly the Asian population, but machine learning allows us to do risk stratification for primary prevention in a very diverse population that we're not able to do with this pooled cohort equations. In fact, in this study, 48% of ASCVD events occurred in individuals who were ineligible for pooled cohort equation application and thus may otherwise have been stratified incorrectly for primary prevention. And this is where we can use it. I want to talk briefly about ChatGPT, as I mentioned this earlier, because this sort of started this whole hype in media. This was released in November of 2022, was built on a large language model, a product of the so-called generative conversational AI. This chat box allows us to have human-like conversations because it recognizes patterns and creates new outputs based on its understanding. Now, this took the internet by storm, crossing 1 million users in the first 5 days. Now just stop and think about that. This is the fastest growing app of all time. And large language models are AI models that can recognize, handle, and even generate human text based on training on massive data sets. This is what helps them identify patterns and helps support decision making. Now, AI cannot, this particular ChatGPT cannot answer completely accurately because it was trained on data prior to 2021. And there have been some issues that have already come out, training biases, because remember, it's only as good as this is training set. There is consensus mirroring, meaning that it always just gives you the majority opinion. So even if a minority opinion is the correct opinion, that's not what you're going to get. Hallucination or confabulation, you're going to get inaccurate information maybe presented in a very confident manner. In fact, we looked up hepatotoxicity associated with statins, and this is the link that it gave, and it's completely wrong. This doesn't even exist, and it can oversimplify knowledge, losing that nuance of clinical practice that we have. So I don't think ChatGPT is something we're going to use every day in our clinical practice, even though people say that. In 2021, the World Health Organization released AI guidelines highlighting its potential to help reduce health disparities, and particularly now with the universal conversation about health equities and how important it is, we think that maybe this is where AI can play a role. Now, the report also warns not to overestimate the health benefits of AI and to mention issues such as unethical collection and use of health data. That could be wrong, algorithm-encoded biases, and of course, cybersecurity, all these issues that we have to take seriously. So I sort of want to take in the next few slides before my end about what some of the pitfalls of AI are. And some of these have already been brought up, but really we have to ensure the accuracy of new data, right? We have to use different data for training as well as different data for testing so that we can have more accuracy. You don't want to use the same data for training as well as for testing. We need to be aware of the risk of biases in the training set. Certainly in complex cases that can create more uncertainty. What about overfitting? The model may be suited for a data set for which it was developed, but not certainly for general application. So we need to think about that. The quality and quantity of training data is also important in the AI model. Remember that old saying, garbage in and garbage out. The training data must be of high quality. So how you apply, who it can apply to. Diversity is important. If you have a data set with just white males alone, it may not apply to white females or the general population. The second problem, of course, is that black box, right? The hard part for us is it's going into and coming out at the other end, but we don't really understand what the processing piece is, that black box. And so to overcome this issue, there is this explainable AI, that technology that's being rapidly developed to help us with some of that. So I do think how we design it is going to be important. The robustness of AI. The AI model must provide us appropriate answer for a wide variety of input data, especially for data recorded in different situations or different locations. Remember, currently, when we do research, AI research usually comes from a single institution because there's no established way to securely integrate a large amount of data between institutions. And I think that's what needs to change. What we need to do is build a model using large-scale data with multiple facilities. And, of course, the use of blockchain technology is considered to overcome this problem. So we'll see more of that. Privacy protection, can't highlight this enough. Certainly the data that gets put in, what's the privacy issue with it? And remember, AI processed data can facilitate the identification of individuals. So, for example, humans cannot identify an individual from a single EKG. But a well-trained AI model may be able to extract personal information such as age and sex from a single ECG. So we have to keep that in mind. So it's necessary to establish a guideline to clearly regulate this situation and ensure safety. And then, of course, AI accountability. This was already alluded to. This is an ethical issue when an AI system fails at a particular assigned task, and this failure has a substantial clinical implication. Who's responsible? The manufacturer who built it, the data owner, or the clinician who used it? And I think these are questions that are out there. Who's accountable for when things go wrong with AI remains really an unanswered question. And I think these are the questions that we're going to have to grapple with, talk about, discuss, and come up with a reason before I think all of this becomes mainstream. So looking into the future, there's one thing clear. Automation is here. It's interesting, even when I was listening to the speaker about the valvular structural disease, somebody in the back says, they're not going to need us anymore, clinicians, that is. And I don't think that's true. Automation won't replace physicians, but I think those using automation will replace those who don't. And I think that's a clear fact. And so I think cardiovascular disease is a really principal cause of mortality and morbidity globally. And I think with the pressures that we all feel about improving care, cutting costs, dealing with the barrage of incoming data, and translating the latest medical advances and knowledge to an actionable plan, I think clinical decision-making for cardiologists is ever so becoming more and more challenging. And I think is adding to some of the burnout, the administrative challenges, all of that. So I think AI certainly holds a lot of promise for better health, reducing cost, and scaling that health equity. So while medicine is arguably the last to apply AI in its everyday routine, I think cardiology is certainly at the forefront of AI revolution in the medical field. And I think the development of AI methods for accurate prediction of cardiovascular disease outcomes, non-invasive diagnosis of coronary artery disease, detection of malignant arrhythmias through wearables, the diagnosis and treatment and outcomes for heart failure, demonstrates the potential for AI in the future of cardiology. And I think with the advances in AI, the Internet of Things, and precision medicine, the future of cardiology is heavily based on these innovative digital technologies. So I think AI in cardiology is limited, however, by the ethical and data privacy concerns that I think still need to be addressed. But I think the intersection of science and technology combined with an innovative mindset, good policies, intentional investment, and co-creation. And I highlight this because CES, a lot of the companies are now coming to clinicians. And I think that part of the reason that we have been so late in the game is that when you think about engineers developing this, they usually come up with the solution and then say, what was the problem we were trying to solve? And I think co-creation allows us to say, this is the problem that needs to be solved. Now help us with the solution. And I think that's a different way. It's much more upstream thinking rather than downstream. A lot of things in medicine are downstream. We take care of problems instead of saying, what can we do upstream? And I think this is an opportunity for us to be upstream. And co-creation, I think, is very much, and I think I'm really happy when you look around the landscape of all companies, AI companies and all that, there are more cardiologists helping co-create all of these solutions than any other medical subspecialty. And I think that's really a good sign. So I think that if we do this, we can usher in a new era of better health in the United States as well as the world. So I think I'll stop here. Thank you very much.
I find it extremely difficult to give this talk because the longer I take care of patients with coronary artery disease or patients who I think have coronary artery disease, the more difficult I find to know what I should be doing. In so many cases, we don't know whether we do the right thing or whether the thing that we did has an important and positive effect. So maybe it's more important to try to avoid doing the wrong thing as frequently as possible than always trying to do the right thing. Taking care of patients with coronary artery disease is very, very difficult because there are so many uncertainties in coronary artery disease. There's this unclear situation of anatomy, ischemia, chest pain, plaque, events, how do they relate? Super complex. I'll talk about this a little bit later. But the longer you do this, the more you understand. It's very, very hard to have a yes and no, black and white, 0-1 decisions when you take care of patients with coronary artery disease. Now, this is what the guidelines, of course, are trying to do. I'm supposed to speak about guidelines and expert consensus documents, and there must be hundreds of such guidelines and expert consensus out there in Europe. In every country you will find something, and most societies have something, and then there are global documents. And I'm going to be focusing on, of course, the European guidelines for chronic coronary syndromes on one hand, the recently published ACC-AHA guidelines, to which many other societies have signed on the assessment and evaluation of chest pain. And of course, there's also the SCCT expert consensus document. All of these documents are very lengthy, so I can only look at a very condensed, sort of trying to extract the essence of these documents and give us some specific advice. Let's talk about the ESC guidelines first, and as Kavitha mentioned, I think we all know these guidelines, and you've all seen this graph before, which basically says that a patient who presents with chest pain, typically what we do clinically is we assign a certain likelihood to this patient that the patient may or may not have chest pain, and many things influence the likelihood, the sort of symptoms, the age, the gender, but also the risk factors. Is there coronary artery disease in the family? Is the EKG normal? Is the echocardiogram abnormal? So it's very hard to exactly quantify the pretest likelihood. The important point the guidelines make, if the pretest likelihood is low, it's perfectly reasonable to do no testing at all. And as opposed to earlier guidelines, the guidelines also say that the pretest likelihood is high, that's all the way over here where it's yellow, it might be reasonable to go to the cath lab immediately without any further testing, particularly if there's very typical symptoms and wall motion abnormalities in the resting echocardiogram. And in between, you have a choice. And the colors indicate that for rather low likelihood, coronary CTA might be the preferred choice. For higher likelihoods, somewhat higher likelihoods, ischemia testing, but it's not exclusive. Completely have the choice, and there are many factors that go into the decision-making, clinical likelihood, but patient characteristics, patient preference, availability, and this is the first guideline that I knew and I know that says local expertise plays a deciding role. Do the test that you know how to do well. There is a sequence, because if you look at revascularization, yes or no, as the end result of your testing strategy, there's on one hand, the question is there's stenosis, on the other hand, the question, does the stenosis cause ischemia? And you can enter this cascade at various points, and the guidelines say, as I mentioned earlier, if there's a very high pretest likelihood, very clear symptoms, LV dysfunction of a typical nature, it's best to go to invasive angiogram immediately and have FFR ready. If you have a lesion of questionable significance, less than 90% stenosis, be able to measure the FFR before you revascularize. There is coronary CTA preferentially to be considered in the relatively low likelihood patients, but not exclusively in the low likelihood patients. Patient characteristics which suggest that the image quality will be perfect, and we don't accept anything but perfect. And local expertise and availability I mentioned again. And then, of course, the ischemia testing have the important extra effect that viability is additional information that you can also get. So if viability assessment is required, this is where you should go. But so many entry points and no sharp black and white differentiation between one or the other. The guidelines specifically say coronary CTA, once again, preferred when there is no previous diagnosis of coronary artery disease. So ESC guidelines do not endorse using CT in patients who have already been revascularized, and emphasize over and over again that the characteristics of the patient have to be such so that we can expect perfect image quality, which includes the heart rate, the breath hold, body weight, and so on. Now, the ACC-AHA guidelines, and we have the chairperson here in the room with us, they also emphasize the importance of the likelihood that the patient has disease or not. And they also emphasize that in low likelihood patients, no testing should be done. You can see the traffic signs over there that says no, no, don't test if the list is low or if the patient is asymptomatic unless there are special circumstances. And one of these circumstances can be the use of the calcium score, which might move a patient from the lower risk to the intermediate risk situation. So this is something that is suggested about class 2A can be considered. Now for the higher likelihood patients, again, there's choices just like in the European guidelines, and it's not a surprise that we find the same situation here because we have the trials, such as the PROMISE trial, which says that both strategies for testing are equally good. So they can do either coronary CT angiography or stress testing for ischemia in those who are intermediate or high risk, and then you can cascade down, and as mentioned before, FFR is also mentioned for those with intermediate stenosis or the combination with ischemia testing. And then if this is positive, go to invasive angiography. Very similar to the European guidelines if you look at the overall picture. Yes, slightly different parameters are used to identify the lower risk patients, which should preferentially go to CT, for example, an age threshold of 65 years is one of the considerations that can be taken to identify, but it's not exclusive. This is just to guide our decision making. Both guidelines emphasize that often you have more than one test, not often. Occasionally you might need more than one test, so anatomy, CT, and ischemia in one or the other sequence might be combined to get the full picture, the full information to proceed. Here's a patient example to illustrate this. This is a lady. I just saw her yesterday before I entered the plane coming here. 54 years of age. She's complaining of chest pain, which is not entirely typical for coronary artery disease. Non-anginal is the better term that should be preferred. But there is something there. She doesn't feel like she used to and somewhat limited in her ability to exercise. The stress EKG was done, and the stress EKG showed this T-segment depression. So this moves her from what she was, a very low-risk patient, moves her to a higher risk category. This is what the stress EKG does. The echocardiography was completely normal. So then the next step, of course, a good next step is the CT angiogram, and this is her CT angiogram with what looked like a very, very high-grade stenosis and 2 little specks of calcification in the proximal LAD. And of course, we rely more on the 2D reconstructions, 2D images, than in the 3D. The 3D is just for the purpose of catching everyone's attention. And if you look at the plaque itself, you can see that it has all the features of what we usually assume to be high-risk plaque. There's stenosis, which is an important component of high-risk plaque. There's positive remodeling. There's this enhancement at the outside of the plaque, which sometimes one of the situations that we use the term napkin ring sign for. So this is a very high-risk plaque, but the anatomy itself, a very, very high-grade stenosis, makes it clear that this is a patient who, according to all that we know, will benefit from revascularization. Plus, we want her to get rid of her symptoms. So she was taken to the cath lab, and this was yesterday morning, and a stent was placed. The important point is she started out as a low-risk patient, and it was the stress EKG which moved her to a higher risk category, still not very high risk, and then the CT clarified on how to proceed. In the ACC/AHI guidelines, there's something that is emphasized over and over again. I read through these guidelines in preparation for this talk, and you can see it mentioned in various ways over and over again. Most patients who come for testing do not have significant coronary artery disease, however you define significant. Among patients undergoing a diagnostic evaluation, there's a relatively low prevalence of obstructive coronary disease and ischemia, about 10%. And there's something that we know intuitively, but that we have to constantly remind ourselves of, which is that the sentence that I like to say is specificity is essential when disease prevalence is low. Because we do have relatively good numbers for cardiac CT, coronary CT angiography. We have 96% sensitivity, which is fantastic, and we have 80% specificity, such as the other non-invasive tests for coronary artery disease. And 80% sounds pretty good, and particularly the 96% sound extremely convincing. But let's assume we have a group of 100 patients with this 10% prevalence of disease. That's not unreasonable. And let's assume we do CT testing in these 100 patients. So out of 100 patients, 10 will have disease. And our 96% sensitivity, is almost 100% sensitivity, will allow us to identify all 10 of these patients. 96% sensitivity, we find all of them. But then we have 90 patients. We have 90 patients who have no disease, right? 90 patients are healthy. And we have a specificity of 80% which means we have 20% false positive findings. 90 patients without disease, 20% false positive findings gives us 18 patients who have a false positive result. So we generate more false positive results than true positive results, almost twice as many. And that's the problem of using testing with limited specificity when disease prevalence is low. That's what we have to constantly remind ourselves. Specificity is essential and prevalence is low, which means we have to do all we can to increase the specificity of coronary CT angiography to as high a value that is possibly imaginable, which includes using the right technology, always taking massive care when we do the scan, and using the test only in those patients where we expect image quality and specificity to be really, really good. Otherwise, don't use the test. So these are the ESC and the AHA, ACC guidelines. Then there's the SCCT expert consensus document, which is more exhaustive. It looks at all the ways in which coronary CT angiography can be applied. It is, of course, written by individuals who are very knowledgeable and also convinced of the technique, which is why some statements are even mentioned twice. The first bullet point is printed twice. And I was studying this to find a tiny bit of detail, difference, but I couldn't. So that shows that people are really, really convinced. And you can summarize that CT is appropriate in chest pain with suspected coronary disease, independent of the pretest likelihood. When a functional test has been done, CT can be appropriate to determine how to proceed. And the SCCT says when you think about revascularization, as long as revascularization is a potential option, this is when CT should be the first choice test. This is based on the results of the ischemia trial. It also says that CTA might be appropriate even in high-risk individuals, not just in the low to intermediate risk group. Also says confidently that CTA is appropriate after bypass surgery and in stents of more than 3 millimeters or more diameter, something that I personally have different personal experience. And also it gives a maybe appropriate rating for FFRCT and CT perfusion if the result after the CT angiogram alone requires further information. So these are the three guidelines. And what they're trying to do and what guidelines have to try and do is to provide us with the possibility to do yes-no decisions. Give us thresholds above which we do that and thresholds below which we do this. And this treats the problem of coronary artery disease like as if there were room for yes and no decisions, but it's not black and white. The field of coronary artery disease is much more like this on the right. Sometimes I wish I was an orthopedic surgeon. But coronary disease is not like this. Just take a minute and reflect on this, right? Here we have a situation, and we know exactly what's happening here, right? We have two lesions, one which is very mild as far as luminal obstruction goes, in the very proximal right coronary artery right there. We see it in the invasive angiogram. You can also see it in the CT scan right there. We have a stenosis that is probably, most people would call it moderate. I do angiography for a living, and I have a very hard time telling anyone how high-grade this stenosis really is. I think it's super, super difficult. Probably moderate is a good expression because it's relatively large. And we can see, of course, in CT, we can see the same lesion. We can also see the plaque right here surrounding the lesion. So we know exactly what is there. We know what's going on, but there's very little about whether this lesion causes chest pain. It might not. Impossible to say. It's also impossible to say whether this lesion will cause an event in the future. It's completely impossible. It might not. It's a high-risk plaque. According to all we know, it's a high-risk plaque. It has a luminal narrowing that we can see very easily. It's substantial luminal narrowing, not super high-grade, but there's positive remodeling. There's, again, this napkin ring sign appearance, very little calcification. It's a high-risk plaque. And we know that high-risk plaque have a higher likelihood to cause an event than plaques which do not have these features. We know this from data right there from the PROMISE trial. 4,000 patients, you can see that the risk of an event is more than twice as high when you have high-risk plaque features. But if you look at the absolute scale of the graph here, you can see that about 5% of high-risk lesions cause an event, which means that 95% of high-risk lesions do not cause an event. 95% of high-risk lesions will not cause an event in the next 3 years. It's not like they all rupture, not at all. And then, of course, we have treatments, and we have no idea whether they're beneficial or not. Because since the events are so infrequent, we do not know whether nothing would have happened hadn't we done anything. Or the fact that nothing happened, is it our treatment, or is it just the natural course? Does a stent really prevent an event from happening? We don't know. And also, statins don't completely prevent all events. They reduce the risk of events. So it's really, really hard to estimate the benefit of the treatment. Lots and lots and lots of uncertainties. We are all imagers. So we know that for imaging and for establishing a diagnosis and for decision-making in general, high contrast is a good thing. And it's exactly the same thing in real life. If you have clearly normal and clearly very, very abnormal, decision-making is very easy. And this is what CT does well. And this is how we like to use CT, to have on one hand the completely normal patient, and the completely normal patient, we will, I can't move forward here. We will congratulate and motivate. Keep going as you have been, you're doing the right thing, but don't start smoking, okay? So we congratulate and we motivate. And then we have the patient who has a very high-grade stenosis, and we educate and we medicate and we potentially also revascularize. I personally, and I don't have time to talk about this, I personally think that my life and our life has become a lot easier after the ischemia trial, because the ischemia trial gives us extreme leeway for revascularization. People usually interpret this as the ischemia trial as saying you don't have to revascularize. But the ischemia trial also says if you do revascularize, you do no harm. So that gives us a lot of leeway for decision-making when you find a stenosis. So these are the extremes. And CT and decision-making, CT is good, and decision-making is easy if you have these extremes. But we pride ourselves in the fact that CT can also provide information in between these two extremes. We also say it's fantastic that CT can also find individuals who have plaque but no stenosis. We are the only test that can do this. CT angiography can find the patients who have non-obstructive plaque, which is great. And you can even see it in the guidelines. Occasionally, the American guidelines mention it. If you want to know about plaque, do CT angiography rather than ischemia testing. What the guidelines do not tell us is how to decide what to do with this. Where is the threshold for initiating, for example, lipid-lowering therapy? This is not written anywhere, and this is, I think, the most important problem that we have. What to do with these findings in the middle? Where is the threshold that allows us, or that requires us, to initiate intensive lipid-lowering treatment and other risk quantification? This is completely unclarified, and it's certainly not going to be an easy way to find out, because it's not a black and white situation. If you think at the extreme on the left, we don't need anything. If you think on the extreme on the right, which is now covered, clearly we need massive treatment. There's something in between, but it cannot be the question plaque, yes or no. Because if we even added just a tiny speck of calcium to this completely normal right coronary artery on the left, it would still be almost completely normal and probably no benefit from lipid-lowering treatment. So lots and lots of information that we still need. Thank you very much for your attention.
Good morning, everyone. I first of all want to thank SCCT for this great organization and for the opportunity to be here with you. Today, I will talk about aortic aneurysms, particularly the thoracic aortic aneurysms and the role of CTA for the imaging. I have no relevant disclosures, and today we will discuss first the definition and classification of the aneurysms, and then the imaging options, choosing the optimal imaging modality with a particular interest in the role of CTA, how we need to measure the aorta on the CTA images, how we need to report the CTAs, and we will finally discuss the surveillance and surgical thresholds for the thoracic aortic aneurysms. So the conventional definition of an aneurysm is actually that any artery that is dilated to at least its 1.5 times expected normal diameter. This can be applied to descending and abdominal aorta, but it's not true for the aortic root and ascending aorta. So if we take a 40-year-old person whose aortic root is expected to be less than 3.5 centimeter, and when you apply this 1.5 times rule, to call it aneurysmal, it needs to reach 5.25 centimeters. But when we look at the data from a population study comparing those patients with a less than 3.4 centimeter aortic root size, we see that when the aortic root or ascending aorta reaches the 4 to 4.4 centimeter, there's an 89-fold increased relative risk for aortic dissection. When we increase that number to 4.5 centimeter, the relative risk increases more than 6,000 times. So this justifies the fact or definition of 4 to 4.4 centimeter is dilation for aortic root and ascending aorta, and equal or more than 4.5 centimeter is accepted as aneurysm. Though these thresholds are intended for the patients who is with an average height and weight and BSA. So for patients who are significantly shorter or taller than average, these diameters need to be adjusted upward or downward accordingly. There are several aortic indexes that are currently used in the clinical practice and clinical research to adjust the aortic size, and even surgical thresholds actually may incorporate indexing of the aortic root and ascending aorta to various parameters. When we look at those, the main indexes, the aortic size index is calculated by the aortic diameter divided by BSA. It categorizes patients in 3 groups. Let me open up the next one so you can see. It categorizes the patients in 3 groups, and as you can see here, with an increase in the aortic size index, there's an increase in the associated aortic complications. The aortic height index calculated by the aortic diameter divided by the patient's height, again, increasing in the aortic height index associated with an increased risk of aortic complications. The cross-sectional area is slightly different. It accounts for the cross-sectional area of the aorta divided by the patient's height. And if it's more than equal or more than 10, it is predictive of increased risk. When we switch to the classification of the aortic aneurysms, it's based on the location of the abnormality. So if it involves the thoracic aorta, it is called as thoracic aortic aneurysms. And if it's in the abdominal aorta, as you can imagine, it's the abdominal aortic aneurysms. Thoracic aortic aneurysms most commonly involve the aortic root and ascending aorta. Hypertension, smoking, hypercholesterolemia, and genetic diseases are risk factors for thoracic aortic aneurysms. And those patients have a modestly increased incidence of concurrent abdominal aortic aneurysms or cerebral aneurysms. For the abdominal aortic aneurysms, the older age, male sex, smoking are independent, strong risk factors. Also, having a positive family history is a well-known risk factor for development of aortic aneurysms. When descending aortic aneurysms extending to the abdominal aorta, they are referred as the thoracoabdominal aortic aneurysms. So how we need to image the aorta? We have CT, MRI, echocardiography, ultrasound in our toolbox, and they all have very important roles in the diagnosis and follow-up of the aortic disease. But if we focus on the CT, particularly for the thoracic aortic aneurysms, CT provides a unique opportunity to image the aorta and its branches at the same time with fast acquisition compared to the other techniques and with a good resolution. But choosing the optimal imaging modality requires to keep in mind the patient-specific factors, such as what is the patient's hemodynamic instability at the time of the scanning, if the patient has any contrast allergy, or what about the renal function? Is the patient able to tolerate the exam if you are wondering to get an MRI study? Do you need any anesthesia? Additionally, the institutional availability of an imaging modality or an expert imaging physician can also play a role in choosing the optimal imaging modality. So if we look at the CTA, as I mentioned, it provides a unique opportunity. We can image the entire aorta and its branches with a high resolution and rapid acquisition in one session. EKG gating is very important because it decreases the motion artifacts, especially if the concern is aortic root and ascending aorta, which can actually cause overestimation of the size in those particular regions. For the CTA, we use contrast agents, and sometimes it is not possible to give contrast to those patients. And if you cannot give contrast, or if you cannot do an alternative method to image the aorta, even a non-contrast CT can be used for evaluation of the aortic size, and it can provide sufficient information to decide if it's dilated or aneurysmal. Okay, if we look at an example here for the EKG gating, this is a patient with a Marfan syndrome. On the plain imaging, this study obtained without any EKG gating, and you can see there is a significant amount of motion in the aortic root. It is hard to measure where the aortic borders are, so you cannot definitely measure the aortic root in the study. On the next one, the patient had a CTA with EKG gating, and you can see that the aortic root is very well defined, well delineated, so we can definitely precisely measure the aortic root and identify if it's dilated or aneurysmal. For CTA measurements, it is very important to have reproducible and accurate measurements because those patients will need follow-up studies, and all of your surgical thresholds treatment depend on the size of the aorta, your measurements. The measurements, therefore, should be obtained perpendicular to the axis of the blood flow at specific locations or locations of abnormalities. For thoracic aorta, those are the actually predefined anatomical locations, landmarks, that we need to provide information and size measurements. When we measure the aorta, we need to provide the longest diameter and its perpendicular diameter as well. We need to do those measurements at the short axis images of the aorta, which is obtained by the double oblique technique that we need to use for the double oblique technique to separate long axis view of the aorta and then identify the location where we want to measure. Again, we need to be perpendicular to the blood flow, and then when we have the short axis images, we need to measure the aorta. This avoids overestimation or oblique imaging of the aorta and provides more precise and accurate measurements. On CT or MRIs, those measurements can be done from inner edge to inner edge of the aorta. But if there is any wall abnormalities such as plaques, atherosclerosis, then we can do the outer edge to outer edge measurements on the aorta. For the aortic root, it has a unique anatomy, and for the sinus of Valsalva particularly, we can do the sinus to commissure or sinus to sinus measurements. But the consistency is essential for surveillance. So which method you use, the follow-up imaging needs to use the same method for comparison. A CTA report, therefore, needs to include the maximum aortic diameter at each level. at the level of predefined anatomical landmarks or any location that is the aorta is abnormal, any wall changes, luminal abnormality, presence of aortic, acute aortic syndromes, the extension of the aortic disease, if there's prior studies, comparison with the prior studies, any prior surgery, any complications, any post-surgical changes, and especially the details of the image acquisition and measurements should be included. Did you have a gated versus non-gated study? How did you do the measurements, on an axial image or on a short axis double oblique image? Are those measurements done by inner to inner edge or outer to outer edge? Those are important components of the CTA report. If we move to the surveillance of the thoracic aortic aneurysms, particularly, echo, CT, and MRI, all reasonable, techniques to use to survey, to do the follow-up for those patients. But if you look at the 2A recommendations, it recommends to scan those patients first at 6 to 12 months, and then if the aortic size is stable, do the follow-up measurement at 6 to 24 months. 6 to 24 months, this is a very wide range for a follow-up recommendation. So the frequency actually needs to be adjusted on a patient level. We need to take account what is the underlying cause, what is the aortic size, how close is it to the surgical threshold, what is the rate of the aortic growth and patient's age. Because if you have a patient with an underlying heritable disease like Marfan syndrome, has an aortic aneurysm which is growing significantly each time you follow up, then you want to follow that patient more closely rather than doing a 24 months follow-up. For the surgical thresholds, again, there is slight differences based on the underlying cause of the aortic aneurysms. The sporadic aneurysms without any heritable disease is recommended to have a surgery at 5.5 centimeter. If the patient has an heritable disease such as Marfan syndrome, this can be lowered down to 5 centimeter. And additionally, at centers with multidisciplinary aortic teams and experienced surgeons, it is reasonable to lower the surgical thresholds further down to the 5 or 4.5 centimeters. As I said, surgical thresholds also can take account into those underlying factors, rapid aortic growth and aortic indexes. For rapid aortic growth, for the sporadic aneurysms, it is accepted 0.5 centimeter in 1 year or 0.3 centimeter per year in 2 consecutive years is accepted as a rapid aortic growth. For heritable disease, it is as the threshold, it is lower, it has a lower threshold and is 0.3 centimeter per year. If the patient in the high risk category by the aortic indexes, then this can also affect the choosing the surgical threshold, surgical time. So in summary, CTA provides actually CTA is a great tool for diagnosis and the follow-up of the thoracic aortic aneurysms particularly. And if you want to further read about this topic, this is a recent guideline from ACC and HAA and endorsed by the Society of Interventional Radiology and Society for Vascular Medicine. And thank you for your attention.
Thank you very much. Great presentations. So I'm going to share with you from a medical physics perspective about scan dose protocols. All right, looks like so. Let's see. All right, so in the spirit of the session, we focus on hands-on troubleshooting. So I'm going to share with you a real-world example. I work in the clinic, so this is some communication happening with my colleague, cardiac radiologist, about a month ago. He's asking me to look at a pediatric patient case. He scanned, and the patient had some prior exams, so 3 total in the range of about 1 year. He's asking, this is the email I copied from. I highlighted DLP there, so his question essentially has 3 exams, why the DLPs are so different. Can you take a look and let me know? So I thought this is good real-world example I'm dealing with pretty frequently, so I thought might be shared with you here today. So first of all, first thing first, we need to figure out what dose metric we talk about here. So it's pretty clear in the email, this is DLP. So DLP stands for dose length product. It's the CTDI multiplied the scan length. A few of common dose metrics we use in CT, CTDI, CTDI wall, DLP we talked about, SSDE, and effective dose. So I thought might be share with you today, discuss a little bit about each of those metrics, what they mean. So it all started with the CTDI. This is probably one of the fundamental dose metrics we use. It's measured at 2 acrylic phantoms, cylindrical phantom, 32 centimeter for the body and 16 centimeter for the head. The measurement is performed using 100 millimeter ion chamber measured in axial mode. So this has been the standard method we use to testing our scanners using as a standard scanner output of radiation dose. It approaches the multi-scan average dose, but it performed in one single scan instead of multiple axial scans together. So that's the fundamental of CT dose metric. And if we look at the dose distribution inside the phantom, particularly for the 32 centimeter phantom, it's not uniform. The center is much lower than the edges. So to have a number that's easier for us to work with, we take the CTDI-W, or weighted average CTDI, which take the 2/3 of the edge multiplied 1/3 of the center. We use helical scan commonly, and one thing related to dose is the pitch. Helical pitch is highly related to radiation dose. So this is normalized, using CTDI-W normalized to the helical pitch will go as the CTDI wall. The reason is very obvious. If we have lower pitch, we kind of squeeze everything together, we have a lot of overlap, the dose is higher. On the other hand, when we have higher pitch, you stretch out, the dose is lower. So by dividing pitch, give us normalization more related to the dose. CTDI wall, however, doesn't count for scan length, right? Let's say we have the same ECG gating scan, and while we scan only the heart, the other scan the whole chest, they have identical CTDI wall, but clearly there's something different between the 2 scans in terms of radiation dose the patient got. So that is where the DLP comes in play. We multiply with the scan length, and for a 30 centimeter chest scan, that will be 3 times than the 10 centimeter heart scan only. So that's what the DLP, and that's where the email coming from. So let's go a little bit further. So again, CTDI wall and DLP, we commonly use those, but one thing we need to be very clear is CTDI is not patient dose. We quantify the scanner output. For one thing very obvious is this is measured on a 32 centimeter acrylic phantom coming cylinder, but our patient come with different size, different shape, so this need to be considered if we want to talk about patient dose. To deal with that, AAPM, so that's my primary society, in report 204 introduced a size-specific dose estimate, or SSDE. This can estimate the mean dose at the center of the scan range from the CTDI wall using a size-dependent conversion factor. So the CTDI wall is scanner output. We can easily directly get on a scanner for each of the patient we scan. If we know that, and also we can know our patient size, this is essentially a lookup table. You can just go to the lookup table, find out what the conversion factor is. That will give us SSDE, which is a reasonable estimate of the patient dose in this situation. Another dose metric we commonly use is effective dose. Effective dose is a calculated quantity that reflects the radiation detriment of a non-uniform exposure in terms of a equivalent whole body exposure. So this was when it was first introduced for this particular purpose and for radiation protection. But of course, recent years we're using this more and more in individual patient risk calculation, which technically is not the right usage of the effective dose. The way to do this is to sum the organ dose multiplied with the tissue weighting factors. The reason we do that is the different organs and have different sensitivity in terms of radiation response. And here I provide a table, and you notice that between the SRP60 and the SRP13, the weighting factor actually is slightly different. Just for clarification, the reason I'm looking at that is the screen doesn't work. So if I'm looking upward, that's the particular reason. There are a couple methods to calculate the effective dose. This is the standard method, but the problem with this is the organ dose is hard to get, right? We cannot directly measure organ dose except some like maybe skin dose that I can put in chamber there. On the other hand, we use a lot of time we use the shortcut method, which we call K-factor, right? Using the K-factor multiplied DLP. There are some generic K-values published, but there's also a lot of recent publications and debate about what K-factor to use. The thing I want to emphasize here is this is a shortcut, simplified version. There's a lot of uncertainty associated with this calculation for the effective dose. All right, so come back to our original example there. So the dose matrix is DLP. So let's take a look what can make the DLPs a big difference. First of all, we always look at how many scans we performed in each of the exam. This can include non-contrast scan, delete scan, etc. So for this particular example, the first exam have a non-contrast scan followed by a contrast scan. The second one has 3 exams, a non-contrast plus a contrast plus a delay, and the third has only 1 exam. So as you can see here, the number of exams absolutely have a direct correlation with the radiation dose we use if the other techniques are the same. So that's one major factor. All right, after that, let's take a look at what about a single scan. The single scan, the DLP depends on the scan length and also depends on the CTDI wall. So there are some difference between the 2 scans. I take 2 scans as an example here. There are a little bit difference with scan length 30 centimeter to 25. So that will be reflected in the DLP, but that's not a whole lot. On the other hand, look at CTDI wall is 0.51 versus 1.58. So that's a 3 times the factor in terms of CTDI wall there. So that will be reflected in the final DLP. Now let's drill down a little bit, look at the CTDI wall. What affects the CTDI wall? Could be the gating techniques. I think we heard about it from the previous speakers about perspective gating, retrospective gating. Could be related to the scan mode, KV, mass, pitch. These parameters can all affect the CTDI. So the perspective gating, as we all know, has a lower radiation dose. The retrospective gating has a higher dose, but it does give us more data and the potential flexibility to dealing with irregular heartbeat. And then in terms of scan mode, there are multiple scan modes available depending on the hardware, depending on scanner model and vendor, what you have in your practice. The axial mode using a perspective gating large area detector that you get the whole scan in 1 heartbeat, 1 rotation. So this is a super dose efficient mode that if you have in your practice. If we don't have the wider detector, it's just a little bit narrow, cannot cover the whole heart, we can do the sequential scan. It's also perspective gating, and we just take the data at the different table locations and stitch them together until we have the whole heart. Usually there's some overlap in between to dealing with, say, the heart doesn't repeat, the motion doesn't perfectly repeat and return to the exact same location. So it's not as efficient as the axial mode, but still considered a dose efficient mode. Of course, the spiral mode is using retrospective gating. This is the highest dose scan mode. But in recent years, we do use the ECG pulsing to reduce the radiation dose. So we try to limit the full dose, full MA only in the cardiac phases we are interested in and drop the MA outside. And by adjusting the height and the width of the pulsing window, we can reduce radiation dose. The high-pitch spiral mode or flash mode available on the dual-source CT scanners. This is also a perspective gating technique that you can scan the whole heart with very ultra-high fast pitch 3.2, 3.4, that you can finish the whole scan in about 160 milliseconds. That is a very dose-efficient scan mode. All right, so again, come back to the example we talked at the beginning. Look at my scan number 1 is a perspective gating flash mode is 1.58 milligray. And the scan 2, these are the patient protocol pages are copied from the clinical packs. And the second one you see that's counter CTA, that's a retrospective spiral gating. That one has the dose of 5.77 milligray. So as you can see here, the scan mode has a big difference in terms of CDDI. And interestingly, the exam 2 actually have another basically a delay scan that use a flash scan. So that's probably an even better comparison. That's the same exam, same patient, same setting, but you have 2 different scan modes. You can see the difference of CDDI. Other factors like the KV has a direct impact on the dose, and the lower KV has been more used in recent years because it gives you better contrast noise ratio as it's close to the K edge of the eye and the more photoelectric effect. Although you need to have a selection based on the patient size and the clinical task. AEC is essentially standard nowadays using in all the CT scanner to help us more use those wisely and efficiently. Reconstruction technically doesn't change the radiation dose. So for example, the clinical example we talked about here, afterwards, this will not change the dose. But it directly changes the image quality, so implicitly impact the dose if we want to maintain the same image quality. Iterative reconstruction, and more recently, the AI deep learning-based reconstruction essentially become the de facto reconstruction algorithms that are used in pretty much all the clinics. And just one example showing the image quality of the iterative reconstruction and deep learning reconstruction to improve image quality and reduce radiation dose. All right, again, I want to come back to the example we scanned here. Low KV are used for all the exams. We use the 70 KV for one of them and 100 KV for the other. This is the reason why the KV are different for the same patient is because the high pitch mode does have a demanding for the tube power, and to accommodate tube power, the scanner jump into 100 KV in this case. The AEC all used, AR all used for all the reconstructions. So the take-home message here, there are multiple things we could look at when we try to do the troubleshooting, including number of scans, scan range, ECG gating, scan mode, KV, AEC reconstruction, etc. With that, I was thanking my colleagues, and thank you for your attention.
All right, thank you very much. It's a pleasure and honor to be here. Thank you very much for attending this session on non-valvular structural heart imaging. And my role is to chat with you about use of CT in studying the myocardium. So cardiomyopathies are a wide group of conditions that, of course, can be secondary to other diseases or can be primary or intrinsic to the myocardium, such as those depicted in this cartoon. There's a range of imaging modality that are usually used in cardiomyopathy, of which CT is just one. Echocardiography, of course, is very versatile, first-line tool in evaluating these patients, but actually it does not provide true tissue characterization. On the other hand, magnetic resonance imaging offers a range of tools and techniques dedicated to myocardial tissue characterization, from evaluation of functional anatomy to infiltration by adipose tissue, iron, edema, hemorrhage, focal scarring with late gadolinium enhancement, we don't really need to speak about that, or diffuse fibrosis with native T1 mapping and extracellular volume mapping. When it comes to CT, there's also a range of techniques. These may not be used routinely on our, standard coronary CT angiogram with an indication of chest pain, but we have a range of techniques. So we have functional remodeling of the left ventricle. We can look at hypertrophy, wall thinning. We can look at capillary rarefaction if we deploy stress perfusion imaging. And we can look at fibrosis with late enhancement. Focal fibrosis, basically exploiting the same principle of gadolinium enhancement with a delayed scan on CT, although the conspicuity may not be as good as in CMR, and diffuse fibrosis with extracellular volume fraction by CT. Now, changes indicative of cardiomyopathy, gross left ventricular remodeling changes can be detected on a standard coronary CT angiogram, generally, more often than not, at least in my experience, as incidental findings in a patient who has either a known cardiomyopathy or an unknown cardiomyopathy. Generally, the main reason for performing coronary CT is actually assessment of the coronary arteries. There are advanced techniques such as delayed imaging. If it gets performed, it can be very useful in describing the pattern of enhancement. It may not be as easy with CT for issues related to conspicuity unless the protocol, the contrast injection protocol and the scanning protocol is optimized. And a relatively new tool, extracellular volume fraction, that can be evaluated with CT and is revealing progressively more and more useful tool. So why am I speaking about extracellular volume fraction? This slide exemplifies why it's quite useful to obtain extracellular volume fraction. This is a population of patients with severe aortic stenosis, low flow or gradient, who were treated with TAVI. And the patient who had higher expansion of the extracellular volume fraction feared a worse prognosis. For every 1% increase in the extracellular volume fraction, there was a 5% increase in the hazard for adverse outcomes. So we can use this as a non-invasive marker for prognostication in this patient. 1 in 7 to 1 in 8 patients with severe aortic stenosis are also found to have cardiac amyloidosis of the transthyretin type. Now, this diagnosis is probably a bit more important than it used to be a few years ago because we now do have effective drugs tackling amyloidosis, which of course in the long term can lead to heart failure. So that kind of diagnosis has become more relevant and is a possible diagnosis by using CT in a patient who is already receiving a CT in a view of TAVI planning. Now, you could argue if it's true that extracellular volume fraction is important and it can inform on prognosis, and if it's very high, especially in the setting of amyloidosis, 45%, 50% expansion of the extracellular volume fraction, do these patients still benefit for TAVI? And the answer is absolutely yes. There's no futility at all for TAVI in patients, even with a very elevated extracellular volume fraction. So the extracellular volume fraction protocol by CT Abbara is embedded in the clinical evaluation for TAVI planning. We do use a technique called axial shuttle mode to obtain a baseline scan before contrast injection and a pseudo-equilibrium scan about 3 minutes after the contrast injection. We co-register the two by using one of the angiographic dataset acquired as part of the standard TAVI planning, and then we subtract them. The hematocrit level of the patient is inputted, and thus extracellular volume fraction maps get created. Now, the axial shuttle mode technique, I'll speak about it again a little bit more in a bit, is a vendor-specific scan technique, which is not ideal, clearly, if we are thinking of implementing this technique on a wider scale. So this is a study that used two standard coronary CTA protocols to achieve, to acquire extracellular volume fraction, with the rationale that these are more widely available and do not require any specific dedicated acquisition technique. So in this study, they used a group by João Cavalcante, included an axial prospective systolic triggered axial scan and a high-pitch spiral mode. And they found a, not negligible percentage of pore image quality associated particularly with the high-pitch scan mode, especially in large patients and with intracardiac leads. So the conclusion is the prospective scan, standard coronary CTA protocol, triggered in systole would be appropriate for this kind of application. And if the overall volume is difficult because the left ventricular wall is affected by artifact, then localized measurements in the septum would be sufficient to estimate extracellular volume fraction in the patient. Now, that's all great, but the routine protocols for coronary CTA are not ideal for the task at hand because they violate the symmetry principle, right? They're based around a partial scan concept, half Fourier transform, so we need limited views to reconstruct an image to optimize temporal resolution. They are designed for that purpose. They are designed to visualize fine detail with great temporal resolution of the coronary arteries. So we have asymmetric views, asymmetric trajectories throughout the body, and this is not great if the aim is not fine anatomy, but measuring ounce field unit in a robust manner. So the axial shuttle mode, coupled with a reconstruction approach called targeted spatial frequency filtration, of TSFF, uses both half scan data for fine anatomical detail and full scan data. The data are selectively filtered, deriving fine detail from half scan with the best temporal resolution and removing the partial scan artifact by combination of the full data. Yeah? So the views of the patient anatomy are all of a sudden symmetric, and the stability of the Hounsfield unit. So you see here on the left plotted some attenuation measured in slices moving along the z-axis in a standard cardiac protocol on the left and with the axial shuttle mode on the right. And as you can see, the variability of your attenuation is removed almost entirely by removing the asymmetry in the patient body views. Of course, things are changing again because new technology is being introduced, is being implemented. And with photon counting CT, for instance, it'll become a lot easier, if not straightforward, to have virtual non-contrast images and iodine map as a natural byproduct of the scanning. So that may make this type of imaging actually quite straightforward. However, if we have to implement extracellular volume fraction by CT as a way of opportunistically screening for amyloidosis and other situations that lead to expansion of the extracellular volume fraction, patients with, for instance, severe aortic stenosis already being evaluated for TAVI procedure, which we have seen is the right thing to do, is a strong treatment for these patients. Then, in order to implement that, in order to screen for amyloidosis those patients, how much standardization do we actually need? And unfortunately, I don't have an answer to this, and it's actually a question or a discussion that I would like to stimulate within the society. It's true that some approaches are vendor-specific, which is not ideal, but they appear to be the best approaches. So how much do we need to standardize to be able to reliably roll this out? There are new developments. There are going to be iodine maps as routine with photon counting scanners. Then there's, of course, the issue of having reliable normative values, populations, right? So maybe it's a discussion that should start among us. And I have finished. Thank you very much.
Okay, great. So we will be talking about patients with arrhythmia during our scan. There's two approaches to it. One is try to have tomorrow's person be responsible to read that case, and the other one is try to fix the issues that arise from when you do the scan. It's not advancing for me. Now it is. Okay, so there's a lot of things we have to do to get a great scan. A lot of them have they happen before the patient even shows up, injection protocol and so forth. We will focus on this initial scan protocol, EKG editing, and then most important, the data reconstruction. So when you're in the reading room, you got to be ready, if it's not the same room as your control room, to go back to the raw data to do some additional reconstruction if you have challenges in your images. So let's start out with retrospective gating, because that allows the most of EKG editing. So just as a reminder, you synchronously record all of your data during something like 5 or 6 heartbeats or so. And then in retrospect, you define with these boxes that we all see on our scanners when you want to reconstruct. And the boxes have 2 characteristics. They have a location with respect to the R2R interval, like the phase, 50% or whatever. They have a width. The width is how much time it takes to collect the data. Also, your temporal resolution. X-axis is time on that EKG. So, of course, you can do multiple different reconstructions. So, for example, you can reconstruct in systole. Here's a case of a myxoma. You can see the mitral valve here. Oops, mitral valve is closed. The myxoma is completely in the atrium. And then without scanning again from the same data set, you can reconstruct something that is where the box is in diastole. You can see in this case here now, the mitral valve is open and this myxoma is prolapsed. And, that's why patients become symptomatic when these obstructions starting to happen. And you can, of course, reconstruct 10 or so different phases throughout the cardiac cycle, and that gives us these cine images that we've been seeing a lot here. Okay, so that's everything going right. And why is it useful? Well, if you happen to have a patient with a PVC here, where you have a slab of 64 or so slices, you have the option to, and I'll show you in detail how that works, you have the option to eliminate that PVC from your reconstruction, ignore that particular set of data, and then reconstruct that data set. And you can see now everything is in diastole in this case. So that would fix an otherwise CAD-RADS N or non-readable study and potentially make it readable. Well, when we use tube modulation, it does affect our ability to do EKG editing. For tube modulation, we want to save radiation, so we down ramp the tube current usually in systole and then ramp it back up for the next diastole, as shown here. So the angle is slightly awkward. When you have, before we do that, the up and down ramping is done actually prospectively, even though this is retrospective gating. It looks at the last 3 heartbeats, averages the time, and anticipates when the next R peak will come. But of course, if you have a PVC, that anticipation is somehow messed up. It comes too early. So where the algorithm thought you would be reconstructing where it has a tube current to your liking, to 100% of what the desired is, that's actually not when you do reconstruct. Instead, you reconstruct like latent diastole as shown here. And the consequence of that, and I'll show you this is a real-life case, is if you have a data set like this, the top slice may have great contrast-to-noise ratio, and then the slice where that issue happened has poor contrast-to-noise ratio because that's where you accidentally down-ramped because you didn't know there was a PVC coming. And then lower down, you're back in the good. Okay, so that's the consequences. So if you had people with frequent PVCs and they're not super young, you may want to choose to not use tube modulation if you do retrospective gating. There's a difference between disabling and deleting a trigger point. So if you have a PVC as shown here, if you, what you want to do is you want your scanner to not use this reconstruction because this is still in systole where everything else is in diastole at 65%. But if you were to delete the trigger point, this would not work. You have to disable the trigger point before, which basically tells the computer, don't use this heartbeat. If you were to delete it, you're basically telling the computer from here to here is your R2R interval. So 30% of that would be, for example, right on the PVC. It becomes agnostic to this PVC. So you want to keep the trigger point, but disable the one before that. All right. And just as a side note, when you talk about percent numbers or milliseconds, you got to remember what vendor they're. So you read a paper, they give you percent numbers. If it were a Siemens paper, they define, so what 50% is pretty straightforward, right? It's exactly the middle between the two R peaks. But where's the box? Well, for Siemens, it's the beginning of the box. So that would be 500 milliseconds after the R peak in this case. But if you look at GE, Philips, Toshiba, Canon, the same 50% is the center of the box. So there, how much time after the R peak is the 500 milliseconds minus 1/2 the width of the box, or 1/2 of the temporal resolution. So you would account for that by subtracting 10% if it is a GE scanner and you're reading a Siemens paper, something along those lines. So the percent numbers are not interchangeable across all platforms. Okay, and then the issues arise when we have things like a not so regular rhythm. For example, here's a longer R2R interval and there's a shorter one. So if we use percent numbers to define our phase, well, these boxes are going to be smack in the middle, right? But they are a different time after the R peak. You can see there's 800 milliseconds and 300 milliseconds in there. How about milliseconds? This is absolute, prospective, like plus 500 milliseconds. That would always be the same time after the preceding R peak. This is great for systolic recons. What you also can do is, since it's retrospective, you can say, well, start at 500 milliseconds or 200 milliseconds before the last R peak. I use that when I want to be as late as possible in diastole before the atrial kick, something like minus 250 milliseconds. So that would always be, in this case, 500 milliseconds before. But you may notice that it is actually very variable compared to the preceding R peak. Okay, so it's important to know if you use percent or absolute. Here's an example of a case that looks a little bit like a stenosis, but of course you all know on a 3D you're not supposed to really do your readings, so you would do a multiplanar reformat, and this looks awfully sharply cut off. And if you look carefully, you probably can see the slab artifact mimicking a stenosis. Okay, so, and then this looks like a half cut off circle down there in cross section. If you go to the EKG, it doesn't look so bad. All the trigger points are right. But what you can do is you can count the slabs so you know which heartbeat corresponds to that slab. And then offset the trigger points by just a little bit. That forces the computer to use different projections to make the same images, as shown in this example. You can see the size of the boxes has changed as well. Okay, and the result of this kind of offsetting or making unperfect your EKG sometimes is that the artifact has been moved just a millimeter or two above your coronary artery. It's still there, but it doesn't affect your coronary artery. So in this case, we would have gone from a CAD-RADS N to a CAD-RADS, well, 0-ish or whatever this ended up being, but evaluable and no stenosis in the segment of the LAD. And this is the before and after. And this is an image, this is from Stephan Achenbach's group. They did this very early on, but it's important. So it's one point in the right coronary artery tracked over time, the X, Y, and Z axis with respect to the EKG. And you can see there are a couple, like end diastole is one of our sweet spots where there's little motion. So that's why we're doing these 75% recons. But then there's also this end systole, which is relative quiescent there. So that's why we're doing these 350 millisecond recons. Okay, so if you take that, you look at somebody with an irregular heart rate. Maybe there's a beat that is about a heart rate of 60 equivalent. You would spread your, if you do every 10% reconstructions, you spread them out evenly through that. So you would have about 1/3 of them in systole and 2/3 maybe in diastole. But in the same patient, 2 beats later, they're at 100 beats per minute. The spreading out evenly results in the majority of the recons now being in systole. And if you want to do, say, late systolic reconstruction to hit that second sweet spot, you could be in, say, 20% in one beat, but it corresponds to, I don't know, something like 40, 45% in the other. So it doesn't add up. So percent numbers no longer make sense because of the sinus arrhythmia or whatever beat-to-beat variability your patient is in. Okay, so how does that look with the usual reconstruction, like this 70%? Well, 70% is exactly where we want it to be in the slow beat, but in the fast beat, it's in systole, so that doesn't work in a patient with this variability. Okay, so how about if we do a percent number in systole, say 30, that looks like just the right spot we want to be. That's not where 30 is with the faster beat. So you would want something like 50% in that, but this is not how you can define it on your scanner. You have to pick one number. So what we do, and a lot of sites, and it's been published, that's the way to go, is prospective, absolute prospective systolic reconstruction, where you say plus from the last R peak, something like 350 milliseconds, for example, because that is identical in a slow and in a fast beat, and it hits that second sweet spot. This is great for systolic reconstructions. All right, so if you do pulmonary vein imaging and you are in atrial fibrillation, say you do that prior to PVI procedure, you can do prospective triggering. You don't have to do retrospective, and just turn on the X-ray tube prospectively in that systolic by defining it as something like plus 250 milliseconds. It gives you very low radiation dose, and you will have little, the least chance for motion artifact. Here's a case, I have many of my own, but I like this one from Stephan, that showed exactly that. This was one of the earliest cases, or in the early days, I should say, where prospective systolic at a very low radiation dose in somebody with a beat-to-beat variability would give you diagnostic quality coronary images. So not a percent number, but plus something like 250 milliseconds. And then sometimes there's some tricks you can use. Sometimes you need the coronaries and you scan them, and you have some beats that are so fast, there is no good sweet spot in that particular beat. You definitely, systole doesn't look good. You want to go into diastole. So what you can do here is you can use this, this disabling. So you disable this one beat where it says 87, and then you do some doubling up of R peaks here. So you lie to the computer. You tell them, hey, there was another R peak here, you just didn't see it. And then you do a late diastolic reconstruction, something like minus 350, which in effect uses this very, very long beat twice. Why do we do that? Because otherwise you couldn't reconstruct, because the table would have moved too much to skip the bad beat. Okay, and so this is the before and after, and again you go from a total non-evaluable case to an evaluable case using that. And then my last example is this. Let's see if this is going to play. Too bad, this is not playing. But I think the sagittal recon shows you that there's really a big difference between the two. If this were to play, you would see beautiful coronaries for like 64 slices, and then the next 64 were like terrible coronaries, unreadable. Why? Because the patient had bigeminy. So every other beat is a bad beat there. So that is completely non-evaluable unless you do some EKG editing. And what we did here is we would have disabled all the normal beats and only imaged in the PVCs or the premature beats, because they had a longer diastole to place our reconstruction. And with that, you can see on the axial images the coronaries are evaluable. This artifact that I've shown you earlier before has completely resolved. And here's a side-by-side reconstruction, imaging only on the bad beats or on the PVC because of the long diastole. So with that, I'm all done, and I thank you very much for your attention.
So thank you, and I thought the previous presentation actually summarised most of what I'm about to say, but I completely agree with all the comments. So my title I was given was Non-Obstructive Disease, Interventional Not, and I suppose this was in an images and interventionalist session, so it's slightly a bemusing title to me in some ways, because you might say, so why bother? If you're an interventionalist, as I am, if you've got non-obstructive disease, you go home and you put your feet up because you've got no obstructive disease to treat. But it'd be a very short talk if I stayed that long. But as we've already heard to a degree, we know that non-obstructive disease is actually really important. It's the cause of most people who come in with a myocardial infarction have non-obstructive disease, but surely by the sheer volume of disease and number of people with non-obstructive disease, of course. And again, as the previous speaker said, highlighted, I think actually when you've got a stenosis, If you've got a stenosis, that means you've got a load of plaque in that very small segment because you've got a stenosis. So it's all about the actual burden of plaque. But PROMIS data, Scott Hart data all show that actually over half the MIs that we presented in those CT trials had non-obstructive disease. And I think we are a bit obsessed, as already said, on stenosis severity. And I've got the same study from Denmark, a brilliant study which you should read if you've not. I suppose they use the calcium score as a surrogate of plaque burden, which you can argue with, but nevertheless, as already described, it was really informative to see that non-obstructive disease and obstructive disease behaves the same if you adjust for the amount of plaque burden. And actually there was a more recent study, the Copenhagen Heart Study, again from Denmark. We've got some great data there. And this was a fascinating study to me because what they did is they did 10,000 people in a cross-sectional study of the general population, and then the ethics committee specifically said they weren't allowed to tell them what was on the CT scan, which is in a sense scientifically great because you can't intervene on what you don't know, right? So this is a true natural history of coronary disease, and only about 10 to 20% of people are actually on statins at baseline. And what they showed was that, yes, stenosis continued to predict events, but they also looked at extent of disease, and those two, that blue and the green line there, is severe stenosis in one colour and severe extent of plaque without stenosis. So again, underlining the same point, that actually stenosis is a marker of disease severity and plaque burden. And even if you don't have a stenosis, you have the same sort of risk if you've got that burden spread out, perhaps not so focally. And I think really, we're all getting more and more comfortable, particularly that CT has now enabled us to actually see this, is that it is about the amount of disease. It's not particularly heretical to say with any condition, the more disease you have, the more likely you are to have a problem. And I just think we need to get beyond this focal element that we've focused on for so long, which historically, of course, has been our main method of doing it because of invasive angiography. Well, what about symptoms? I suppose I do have to talk about symptoms, and I think I completely agree that stenosis is about symptoms, and if you're about prognosis, it's plaque burden. But my talk was entitled Non-Obstructive Disease to Intervene or Not. Well, clearly you're not going to put a stent in someone who's got non-obstructive disease, and we should, though, talk a little bit, very briefly, about INOCA, as it seems to be getting more and more popular. These are some of the thoughts and processes that people have done. I personally struggle with doing invasive assessments of patients who have non-obstructive disease with anginal type chest pain, because we don't have any good treatments for it, instrumenting the coronaries and doing these functional tests that we don't really know what they mean and what the treatment implications are, because a lot of the vasodilators don't work, and I do really struggle with it, I suppose. So even if you have non-obstructive disease with demonstrable ischemia, I question it a little bit. And I suppose one of the data I want to share with you, I suppose, is the Chow ischemia study, which I thought was quite informative. So in ischemia, of course, you got in there whether with a stress echo and evidence, objective evidence of significant ischemia, and you had a CT to exclude left main, but that CT was also used to exclude normal coronary arteries. And the Chow ischemia was essentially those people who had normal or non-obstructive disease, and they then went on to study those patients. And what you can see is that the ischemia test, actually in the non-obstructive disease group, was identical to the distribution of ischemia on the obstructive disease. Now, a cynic would say, well, that's just, it was all done badly, it was a false positive test, etc. But this is what we're seeing. These are people presenting with symptoms, and they're having objective evidence of ischemia on the test, even though they've got non-obstructive disease. But what I found quite interesting, and people do argue about this, but what they did was they repeated the scan a year later and perhaps reinforced the cynic's view that this is a false positive test. But nevertheless, at 1 year, the vast majority of those scans actually were normal. No evidence of ischemia had gone. And I think also on the far right there, if you actually try and correlate the degree of ischemia with the symptoms, actually it's very difficult to show a relationship between the symptoms and the ischemia. So I think overall, when I think patients have non-obstructive disease with anginal type symptoms, for me, the take-home message is it's often self-limiting, the vast majority get better, and firm reassurance is usually a good strategy, although there is a specific subgroup that seem to have persistent symptoms. But the ones that have the bad outcome are the ones with non-obstructive disease. So what intervention are we going to do in this non-obstructive disease? Well, I'm not going to follow the guidance of this little soundbite. Clearly, we do need to help patients address the consequences of their behaviour and give some treatments. So I just want to flag up a little bit, and this is from data from Adam Tims's group on the left-hand side, which highlights that if you go to your cardiologist to get assessed for your chest pain and you're told you don't have angina, actually you do very well, whereas the people that have angina have more event rates. But if you actually look at the number of MIs that happen over the follow-up period, a third of the MIs actually happen to the people that the cardiologist said, actually you don't have angina due to coronary disease. Now in Scott Hart, which is the data on the far right there, you'll see that the biggest reduction in event rates were in the people that had a final diagnosis of not having angina due to coronary disease. Now the reasons for that are several-fold, because some of the people that would have been said they had no angina due to coronary disease actually were reclassified as having angina due to coronary disease, so obviously event rates will fall because you've correctly identified them now. But also in that group of no angina due to coronary, there's a lot of people with non-obstructive disease. And these are the sort of event curves that we saw in the Scott Hart trial. You can see that people who didn't have angina also got a benefit. And actually, if you look at the hazard ratio, actually, arguably, it was the biggest benefit proportionately. Not statistically significant because we're doing this subgroup analysis and therefore the power drops off. But actually, that is the group that seems to be getting a lot of benefit. And that, of course, is because what we're doing is identifying non-obstructive disease. And when you looked in that group, 50% of people had coronary disease. Interestingly, up to 10% actually had obstructive disease in that non-anginal chest pain group. And actually what you can see is that when you revascularize them, it really makes no difference in their endpoints, but actually their new preventative therapy actually goes up quite dramatically. And on the far right there, you can see an assessment of people who actually take their statins according to their risk score. And if you're told you've got non-obstructive disease, you do take your statins and you take your treatment. So clearly, non-obstructive disease, do you intervene? Yes, you do. You give them secondary prevention, even when they've not got angina, even when they've got no symptoms, and that should translate into benefit. Now, I've sort of gone a bit over the evidence there, but that is something we're hoping to address in Scott Hart too, taking asymptomatic people and doing screening for the disease and treating them with therapy. But that certainly is, from my point of view, the intervention that you should be doing. Should be doing any revascularization? Of course not. And even if you had obstructive disease and you're trying to avoid MI, arguably you shouldn't. And we can also talk about ischemia, of course, but perhaps I better not. And we should just keep it simple. So I think non-obstructive disease on CT, should we intervene or not? Well, I think it's important. If you've got non-obstructive disease, it's a risk marker. It is related to outcome, rarely associated with symptoms and persistent symptoms. And I think I'm slightly unclear about INOCA myself. We could discuss that. But clearly, the intervention of choice, the only intervention of choice that you should be thinking about is making sure they have lifestyle intervention and secondary prevention. Thank you very much.
Good afternoon. Thank you for the organizers and to the society for this opportunity to speak. So I'll try to describe for you kind of some of the practical aspects of having 3D modeling incorporated into your practice, and then some quick examples. So why would we want to kind of utilize 3D printing and modeling for CHD? Now, we know echocardiography is kind of our mainstay of imaging, and we use sweeps to kind of recreate the three-dimensional anatomy in our mind. But it's been shown that people differ in their ability to really do that, and so the ability for someone to perform something called mental rotation, where you imagine a three-dimensional structure from different aspects, really varies from person to person. So once you've kind of decided that this is something useful that would benefit your patients at your center, you need resources to kind of start this type of service. And so the different components that really are important, you should have access to 3D image data set acquisition. So whether that's from CT or MR, obviously other 3D data sets can be used to create 3D models, but these are kind of the mainstay. And then having an image post-processing software that can be freeware. We use commercial software called Mimics, but certainly things like 3D Slicer have been used elsewhere. And then you need personnel, so that's usually someone to perform the post-processing. I do it at my center, but certainly other centers have engineers to help with that as well. And then if you want an actual printer, you need institutional buy-in for printer space. This is not a trivial issue. At our center, it's really hard to even try to find any type of, or negotiate for any type of space. And so you find yourself kind of thinking about non-traditional spaces to put a printer. And then obviously the cost for the printer, as well as an area for post-processing of the models. And it really does overall come down to money. And at different points in my career, I've had different funding availabilities. And so I'll show you a few examples that I used when I had a bit less access to funding for this. And then alternative options, if there are certainly services that you can send a CT and MR to, and they will create the digital model, and if you want the print, they'll print it for you, and they've become more cost effective, so that's also another option. So we start with a 3D data set, CT or MR, and obviously the quality of the model is directly related to the quality of the image data set, and so we do kind of focus on the area of interest. So if you're looking at intracardiac anatomy, you do want kind of a homogeneous blood pool. But here, this is just an example of segmentation of the left atrium. So you highlight the area of interest, you create the digital model, and then that is hollowed for blood pool segmentation. You can also do myocardial segmentation and highlight the myocardium in cases where that is more relevant. There are many different kinds of 3D printing technologies. One of the kind of most, the cheapest essentially, and the one that most people are familiar is called material extrusion, and it's also called fusion deposition modeling, or FDM. Basically that involves a thermoplastic, so a plastic that is fed into a nozzle, and it in a solid state, and then it melts because it is fed through a heated nozzle. So layers of this thermoplastic are placed down on a platform, and the platform moves, and then subsequent layers are placed on top of it. So when I was a fellow at Sinai, our surgeon wanted to get more involved in implementing 3D printing. We acquired a Mojo printer, which is an FDM printer, and I didn't really have access to much in terms of funding, and so this, for example, cost about $3,000 or $4,000, and it was refurbished. Here on the right side, you see the different components in that printing space that are involved with that printer. So this is an example of kind of a simple print from that printer. There's model material and support material. The support material allows for kind of overhanging pieces to be supported through the printing process, and this is a complex Fontan patient that we printed, including the liver, because they were being considered for heart liver transplant. So at Columbia, we have one really high maintenance printer, which is the J750. To give you a sense of the cost of that costs about $400,000. It's a polyjet printer and has really fine resolution, but just to give you a sense of, you really have to take account of the resources available at your center, because we have this printer which prints in multiple materials and multiple colors, and it's in hibernation because we don't have an engineer to run it. And so because we needed a working printer for some of my research, we recently acquired an F120, which is a FDM printer. It has relatively good layer thickness, and the cost of this is about $12,000 or $13,000, but it's really doesn't take up much space, and it's really user-friendly. But it only prints in one material and one color. So in terms of who are we using this technology for. So early on, those of us who were involved early on in incorporating this technology was really all about conotruncal defects and double outlet right ventricle, and certainly we continue to use it for those patients. This is kind of the overview of how we use it at Columbia. So mainly complex intracardiac anatomy, also for VAD and transplant planning, and we've also used it to look at kind of the aortic root characteristics of anomalous coronaries, and then certainly other kind of more extracardiac anomalies as well. So this is an example of a patient with a coronary artery to RA fistula, and I segmented this in different colors for the different parts of the heart, and you can see that the coronary artery fistula is in yellow. I also created a single color print with the single color model where you can see the intracardiac anatomy and kind of the course of that fistula from the aortic root to the RA. This was printed through Formlabs, which is a different type of printer, but it allows to print in like this transparent material, and that was useful for our colleagues to see the catheter course and planning of that procedure. This is another kind of congenital heart disease we've been using 3D, mostly digital modeling, sometimes printing, but it's for sinus venosus defects, and it really allows us to see if transcatheter closure of that defect is an option. The CT on the left upper hand, you can see the area where placing a stent could potentially create a wall at the posterior aspect of the SVC, allowing the anomalous vein to drain directly to the left atrium. And so this is a case published by some of my colleagues, and you can see the post-intervention CT shows this wall of the SVC that was created by this covered stent. For anomalous coronary arteries, we're still figuring out what are high-risk characteristics, but certainly looking at, slit-like orifice and the intramural course has been really useful through this digital modeling. You can see in the upper right, there's a slit-like ostium for this patient, and we modeled it for the surgeon. And in the left lower corner, you can see it represented well what they saw in the operating room. A few years ago, we demonstrated the potential utility of 3D prints for VAD placement. This is a study which is funded now under a K23. So it's a multi-center study with about 16 or 17 centers around the country, and we're randomizing, it's a randomized control trial, randomizing to either model or no model for patients with single ventricle lesions or systemic RVs, and we're trying to assess the potential utility of these models, because at different centers there's different surgeons in terms of their experience with congenital heart disease, and we think potentially in patients who are being operated on by surgeons who may have a bit less experience with congenital heart disease, these models may serve as a good map. And certainly we've been doing some digital modeling for VAD placement in patients in whom we're wondering if the chest wall may be too small for a ventricular assist device to fit. And so we have actually the STL files for the different types of heart mates, for example, and then we can pull them into the digital software and try to place them into the apex and see if they'll fit within the chest. So the other kind of area that we utilize 3D printing and modeling includes education. We've demonstrated utility in, for example, medical school teaching, and we found that we created models for like a range of different complexities, and we found that with increasing complexity of the congenital heart disease, the medical students' self-reported learning was higher. And I use this for bedside teaching all the times when I'm rounding in the ICU. It's kind of become a joke because I just will pull out a model from my pocket, and they're always kind of waiting for me to do that. But I've had really great reception from not just the trainees, but the people who are sometimes most enthusiastic are the nurses. If you think about it, sometimes they don't really have that exposure that our fellows do, or some of the residents, to some of this complex anatomy, and they get really excited when we pull this out, and they'll pass it around. So that's another area that we've been utilizing this. We also, for those of us who do fetal counseling, we use drawings typically for fetal counseling, and obviously there's variation in how well people draw. And so in trying to standardize this, we did a pilot study just looking at the feasibility of implementing modeling for counseling, and patients were essentially randomized over the course of a year, and we demonstrated feasibility, and it looked like there was some utility in decreasing parental anxiety and increasing parental learning. And so I'll touch on virtual reality a little bit, just to show you that it's kind of a continuum of workflow, because those digital models I showed you, I can actually pull them into a virtual reality environment. And the work really is more about the segmentation, less about this different type of imaging. So for those of you who you're probably a little bit familiar with this, but virtual reality systems allow you to have complete immersement in a digital environment, and so typically that involves a visor, and then augmented reality involves kind of overlay of digital models or digital objects within your own world, so you can still see your environment, and merged reality kind of allows you to interact with those digital models. And so this is a system we have, which is an Induvo system. On the right, it's a video of our surgeon, Dr. Basha, showing, so he's within this environment, and he's manipulating a DORV, and within the environment, I'll show you on the next slide, you can crop the model, you can pull in pointers, and we can even project this onto a screen so that he can describe what he's going to do to the audience. So this is a patient. I'll just show you a brief example of potential like PDA stenting in a patient with DTGA, VSD, and pulmonary stenosis. And you'll see the duct kind of inserts into the proximal LPA, and it's tiny at the site of the LPA insertion. You can see that right there. I think I'm going to scroll again. But also there's a tiny part of the PDA. And then this is a sagittal view of the same. And so I created a digital model, so same workflow process where we create a hollowed model using the blood pool segmentation process. And so I have to set up the virtual reality system, which probably takes about 10 minutes now that I'm a bit facile in it. And you wear this visor and you're in this environment, and this is all you see. And whatever digital objects are in the environment, you can make them bigger, smaller, manipulate them. And so here you can see the PDA, aorta, and you can see where the PDA kind of inserts into the LPA. In this system, there's a plane that allows you to crop in and out of a model. So you can have this model in front of you, you can crop it, and you can walk around and look at it from different aspects. And then in order to try to simulate stent placement for this case, I had to search online for a stent file. And so the format is a STL file. So you can pull the stent in, make it bigger or smaller, and then I basically placed it where I thought it should go, which, I'm not a cath doc, but I did the best I could, and then you can crop in and out of it, see what the feasibility is of stent placement, and manipulate that as well. So obviously it simplifies a bit stent placement. It's not this easy, but it can give you a sense of the feasibility of it. And then lastly, I'll just touch on, we don't get reimbursed for this, right? And sometimes it takes many hours to create these models, but we are headed in the right direction. There's been a lot of work through the RSNA to try to get approval for some of these codes. So they count under a category 3, which is really for developing technology. And there are codes that you can use, although you don't really get reimbursement at this point. But, publishing on this data certainly helps with moving towards the goal of having reimbursement long-term for our efforts in this area. So for us, the impact of 3D models has really been, makes pre-procedural decision-making more defined. We think it may decrease time in the OR because of better preparation. the information to parents and patients can be more comprehensive, and also the educational value has been valuable for us. And then, so if you want to create and sustain a 3D modeling program, you should communicate with your team to see what their needs are. You have to demonstrate utility and innovation and application so that you have buy-in from your hospital and essentially funding to support this. Look at how you can streamline your workflow, in part by having someone else trained to segment so you're not the only one taking on that burden. Be cost effective whenever you can, and then publish your work whenever possible. And then the limitations of this technology include the time, how much time it takes to do all these different steps, the costs associated with all these different people, and all of this hardware and software associated with it. Technically, valve representation is an area we could do better in, and we're working on creating more data which can support its use and its comment on its value. And then waste is another thing in terms of just for the environment, kind of accumulating 3D prints that's a whole nother topic. But thank you, I hope this was useful.